Okay, good morning, everybody. Thank you for joining us as usual. We'll get right into our weekly updates so we can present our main presenter we're excited to have today. Dr. Collins, we'll start with you for updates. Thanks again for being with us every week.
Sure. Can everybody see?
Yes.
All right, cool, thumbs up. So just a quick update on numbers for COVID-19 here at Stanford. Always fun to get my slides to actually work. There we go. So this is several trend lines basically looking at cases at Stanford and hospitalizations. So the bar trend line is new positive cases by week through Stanford Healthcare. You can see that since our peak here in December and January, that's definitely fallen off in the recent weeks. The other trend lines are basically our census at 500 and 300p. The top one is all patients put together. This is COVID positive and COVID cleared together, or what we're calling our COVID impact. You can see as well that has significantly come down since the peak, in January. As far as breaking it down between those needing ICU care versus acute care, those are the two trend lines at the bottom. You can see that the ICU numbers have continued to come down. The numbers for what is called the AAU have kind of plateaued in recent weeks, maybe because this is both patients coming out of the ICU and still coming through the ED. I think something similar was seen with our peak in the summer, but certainly a trend that we'll want to follow. And then just showing again our demographics, we reran them through now February 7th. And looking at just those patients in Palo Alto, that's 1,365. Breaking it down again in terms of about 22% needing ICU care, a little more female than male. Our age range remains about the same as far as those most affected by racial or ethnic background still remains a majority from the Hispanic or Latinx community. And then looking at deaths, so we showed some data from a different data set last week that showed that our mortality rate appeared to increase in January. We reran it with this data, and this is the first time that rate is above 7%. So it does seem like with our most recent wave, we did have a little bit of an uptick in the number of patients who unfortunately passed away. So with that, I want to make sure I thank all the people who helped with all this data, and I'll stop sharing.
Wonderful. Thanks so much, Dr. Collins. We'll move on to Dr. Chang.
Good morning. Thanks. It's nice to be back. Thanks for inviting me. This morning, I'm wearing a different hat. I am representing Upi Singh, our Chief of ID, who couldn't be here today. So I'm presenting this on her behalf. As you may recall, about 2 months ago, we started outpatient COVID monoclonal antibody infusions at Stanford. And thank you to all of you out there who referred patients to us. As with most of the nation, and has been reported regularly in the press, we've been hampered by a lack of space to infuse and a referral and ordering process that frankly was confusing and lengthy and really limited our overall capacity and ability to serve our patients. To make a sufficient dent in the community health and our hospital census, we had been targeting 20 infusions a day using the numbers needed to treat of 9 cited in one of the early studies, and in average length of stay of 5 days. We thought we could theoretically reduce census by up to 10 persons a day, and that we thought that would be a material impact. But so far, we've only been able to average less than 2 a day. So this morning, we wanted to share the good news that thanks to the extraordinary commitment of our SHC partners, leadership and staff, that we've set up a high capacity infusion center at our Hoover Pavilion with a capacity of 20 to 30 infusions per day. But equally important for those of you out there who have been trying to refer patients, that I'm now putting up our workflow, we have radically streamlined it so that now you can just enter a referral into an online web portal, and we can share this slide with you, but it's hyperlinked right there. You don't need privileges, you don't need Epic access, and the most important thing is after you submit the referral, talking to the patient, making sure they qualify and the patient is interested, the program is going to take it from there. The choice of the drug, which is evolving, as you know, entering orders, writing the Epic note, contacting the patient, organizing the logistics, and even the next day follow-up phone call. Again, with hats off to our FCC colleagues, the program is going to focus on promoting health equity by offering it at no patient charge to all persons within our catchment area, regardless of whether or not they're a Stanford patient and regardless of whether or not they have health insurance. This is part of our commitment to serve the entire community during the pandemic. And so now we're extending that commitment not just in testing and vaccination, but now in the treatment access as well. And in addition, we're actively reaching out to community clinics and county hospitals. And in cases where there's a drug shortage, we actually committed to clinically prioritizing these patients as well as persons from adversely impacted racial and ethnic backgrounds, as we all know that both the incidence and the mortality is much higher in these groups. So on screen is the workflow. We'll share this with you, but I just wanted to share this good news and encourage all of you to refer your patients. It's really seamless and easy now. And again, kudos to our SHC colleagues for their commitment and lightning speed in standing this program up. Thank you for your attention.
Thanks so much, Dr. Chang. We'll move right on. And then to end, we have Dr. Pinsky, who's going to talk about the variants. Thanks for joining.
Thanks, Errol. Let me share my screen. So we've been continuing to monitor for variants in our patient population. We've screened over 1,700 specimens. The news of today is that we have identified 2 cases with the South Africa strain. This would be the where we would be the 4th state to identify this variant in the United States, and the 10th and 11th cases. There were a couple questions in the chat already about the variants. The UK and South Africa strains are estimated to be approximately 50% more transmissible. The UK strain may have more severity. That was reported by Boris Johnson, but has not yet been confirmed. So it's not entirely clear whether these variant strains are cause more severe disease. And there's certainly evidence for the South Africa strain that it is it is resistant to vaccination, meaning that more people become infected. If more people can become infected with the South African strain if they have been vaccinated. This was shown in the Johnson & Johnson trial and Novavax trial, and more recently, a trial in South Africa of the AstraZeneca vaccine. However, in all of these studies, vaccination has reduced the severity of disease, and there is no deaths reported in those individuals that were infected after vaccination. So that's some good news. As Song just talked about, there is a lot of interest in these monoclonal antibody therapies. And so just a word on that, the South Africa strain in particular is relatively resistant to some of the single monoclonal antibodies. That's shown down here with fold reduction. Here's the Lilly-BAM antibody. Here's the combo, which would be recommended in cases where some of these variants are identified. And then similarly for convalescent plasma or vaccinated plasma, if it's blue is bad here. This is light blue is 3 to 10-fold reduction in neutralization, whereas dark blue is greater than 10-fold. And this data can all be found for all of the variants, and a number of the single mutations, such as the California variant, can be found at covedb.stanford.edu, which is a website that Bob Schaefer has put together, and really extensive literature review and description of all of the studies really about variants and resistance to potential therapies and vaccines. So thank you.
Dr. Pinsky, thank you as always for that. And thank you for all our updaters today. So happy to now move on over to our main presenter. Before we do that, I just want to mention next week we have a topic, delivering diversity inclusion, moving beyond pipelines to accountability and measurable change, with Dr. Carla Pugh, along with our panelists, our own doctors, Tamara Dunn, Dr. Valentine, and Dr. Mays. And then the week after that, we have Dr. Rhea Boyd talking about the politics on representation, on diversity, inclusion, and justice. So we're happy to and looking forward to those presentations, but particularly looking forward to our presenter this week. And I'm happy to have Dr. Harrington introduce Dr. Capers.
Great. Thank you, Errol. And it really is a privilege to introduce my good friend and colleague, Dr. Quinn Capers, who's going to join us as we continue to celebrate Black History Month here at in the Department of Medicine at Stanford. Dr. Capers is a graduate of Howard University and the Ohio State University College of Medicine. He then did his internal medicine and cardiology fellowship, as well as his interventional cardiology training at Emory University. From 2009 to 2019, he served as the Associate Dean of Admissions at the Ohio State University, and the changing of Ohio State was remarkable during Quinn's tenure as the Associate Dean of Admissions. In 2020, UT Southwestern was fortunate to recruit him, where he joined them as a professor of medicine, the Associate Dean of Faculty Diversity, and the inaugural Vice Chair of Diversity, Equity, Inclusion in the Department of Internal Medicine. Dr. Capers is a passionate advocate for enhancing diversity in medicine as a way to eliminate healthcare disparities. And I know that he'll speak about much of the statistics of this in his own work during his presentation. I want to call particular note to some of his national awards that recognize his leadership and some of his recent leadership positions. He has been awarded the American Heart Association's Lynette Clinician Educator Award. He has recently been awarded the Exemplary Leadership Award of the Association of American Medical Colleges Group on Diversity and Inclusion. He's received the American College of Cardiology's Distinguished Leadership Award in Diversity and Inclusion. And just this past year, he was elected to membership in the Association of University Cardiologists. Quinn is an extraordinary leader. He's a passionate advocate, as I said, for diversity in medicine. He is also one of my favorite people in American cardiology, and I'm absolutely thrilled that he's joining us here today to again, celebrate Black History Month with us and to share with us the work that he's doing. Dr. Capers?
Thank you so much, Bob. Well, I really appreciate your comments, very complimentary. And I'm looking forward to continuing to work and collaborate with you, and just want to congratulate you for being such a leader in diversity yourself. You are a senior leader who actually, as we say, walks the walk, and I'm privileged to have you as a friend. I'm privileged to be able to speak with you at Stanford here today. You are such leaders in this work, and I really do appreciate the invitation. So let me get my slides up here. So I'm trying to get to my presentation mode. Let's see. I'm sorry, I'm trying to get my full slides up there.
No problem. Your screen looks good. In the bottom right, or clicking on slideshow might.
How about that? You got it?
Perfect.
Okay. All right.
Beautiful.
Thank you. So I wanted to start off this talk again. Very happy to be with you, but I want to start off with a piece of art. This is a very important piece of art to me. And one of the reasons it's so important is because my daughter is the artist. What you're looking at here is the image of a Black physician, and that Black physician is being crushed by two external forces, but he's fighting back. You see the determination on his face. When he looks to his right, he sees a virus that is disproportionately killing people in his community. And when he looks to his left, he sees racism, here evidenced by police brutality, that also is disproportionately killing people in his community. In the background, cities are burning as people are protesting, and he carries that weight with him as well. This is what it has been like for your African-American colleagues in the last 12 months. So think about this when you pass your Black colleagues in the hallway. This is what they have felt, but that look of determination on this doctor's face is what we also carry with us. So I wanted you to feel this. This is a picture of racism and bias in medicine as experienced by physicians. Now, the events of 2020 have really brought into focus how racism affects American life. As we all saw, cell phone footage, video, one after another of horrific events of police brutality and racism and really executions of Black people. The whole world cried out. It was gratifying somewhat to see protests in Amsterdam, in Switzerland, in Iran, and in most states in these United States, protests against racism. And academic medicine responded with some bold anti-racism statements. All academic medical centers made these bold anti-racism statements. I'm sure yours did as well. And I think that's good. That is a good start. But I'm going to make the case today that the most powerful and the most durable anti-racism statement that an academic medical center can make is to diversify our ranks. So let's have a little fun with a multiple choice question. I always have been told that at Stanford, you're good test takers. So you've got good test taking skills. So we're going to explore this in the guise of a multiple choice question. And that is, the question is, why do we seek diversity in medicine? And this is important because if you advocate for diversity in medicine, as so many of you do, I know that occasionally you get some pushback. Why? Why are we doing this? Are we doing this just to be politically correct or for some other nebulous purpose? Why are we doing this? Why do we need to change our systems to try to enhance diversity? So I'd like to give you some information to help you push back against that pushback. But first, I'm going to ask for your help answering this question. Now, it's a multiple choice question. It's a best answer, single best answer, multiple choice question. And as all good test takers know, the key to a multiple choice question is you start seeing first what you can rule out, and then maybe you're left with the answer. So the question is, why do we seek diversity in medicine? Here are the options. Is it A, because physicians who train in diverse environments rate themselves as more comfortable treating minority patients? Or is it B, because underrepresented minority physicians are more likely to serve the underserved? C, because minority patients are more likely to follow the recommendations of minority physicians? Maybe it's D, because more minority physician scientists will help us diversify clinical trials. E, is it because diversity in medicine will help us reduce racial healthcare disparities? Or is it F, that diversity on research teams will enhance the impact of research? Remember, this is a single best answer. So what you need to be doing now is figuring what can you cross off to get to the answer. Okay, let's explore. This is a paper by Saha and colleagues published in 2008 that looked at surveys of white physicians, and it asked them about their comfort, their self-identified comfort treating diverse patients, patients from cultures different from their own. And it also asked them about their ideas about attitudes and access to care. And it ranked them, it looked at where they went to medical school and the diversity of the medical school. And it ranks the diversity of the medical school they attended from lowest to highest. And they found a correlation. They found that the white physicians who attended more diverse medical schools had more cultural competence in terms of their self-reported comfort treating diverse patients, and they had more egalitarian attitudes about access to care. In the summary, they concluded that in a cohort of more than 20,000 graduating medical students, white students, attending more racially diverse schools rated themselves as better prepared than students at less diverse schools. And this is important. It shows you that diversity not only benefits minorities, but it benefits majorities. And so some of you probably feel pretty good about A as the answer, but let's continue. Minority physicians are more likely to serve underserved patients. I had an idea when I made this slide. What I wanted to do is show you every study. I wanted to put every study in the last 50 years that has shown that minority physicians are more likely than other physicians to serve disadvantaged and underserved patients. But the slide wasn't big enough. So you'll have to settle for 10 studies from 4 different decades, the 80s, the 90s, the early 2000s, and the 2010s, all showing remarkable consistency in that Hispanic, Black, and American Indian physicians are more likely than their counterparts to choose settings where they are serving the underserved. So this is not something that most people will even debate. It is a truism. It is a legacy. And so you're probably feeling pretty good about B as your answer of why we should diversify medicine. Let's continue. This is an interesting study, and you might have heard about this. Colleagues not too far from you in the Bay Area in Oakland studied the willingness to have preventive medicine procedures done by Black male patients based on the race of the physicians. So in a series of preventive care clinics, they studied the response of these patients based on whether the physician recommending the studies were Black, white, or Asian. So all the patients were Black. In this clinic, they were told, here's what's available today: BMI measurement, blood pressure measurement, glucose screening by finger stick, cholesterol screening by finger stick, and a flu shot. The doctor walked in and recommended that the patient have all of those things. And we're going to look at what happened. But first, here's something that's interesting. What the researchers did is they looked at the progress notes written by the doctors. And they saw a pattern. They saw that the progress notes written by the white and Asian physicians, remember all of the patients are Black males, the progress notes written by the white and Asian physicians were short, succinct, very businesslike, and very to the point. Here are some examples of those progress notes. Weight loss. That's an entire progress note. TB test. That's another one. That's the whole progress note. Anxiety. There's a one-worder for you. They saw something quite different, though, when they looked at the progress notes that the Black physicians wrote when seeing the Black patients. They seemed to reflect a deeper level of listening. They seem to be more inclined to take into account the social determinants of health and the ecology of the patient on whether or not the patient would respond, and the patient's frame of mind. So here are some examples of those notes. Needs food, shelter, clothing, and a job. Flu shot makes you sick, but he got one anyway. Subject yelled at me, then agreed to get the flu shot because I recommended it, and made patient laugh. Do you feel that? Do you feel a difference, a different level of engagement? And dare I say it, perhaps a different level of compassion for the patient. And it is perhaps that translated to the finding, which was that those Black male patients were more likely to get their glucose checked, to get their cholesterol checked, and to get a flu shot if it was recommended by a Black as opposed to a white or Asian physician. Staying on that topic, here's another paper by Saha and colleagues. He's been a wonderful contributor to this data. Here, instead of using what we sometimes use, standardized patients, actors playing the role of patients in the study, he used standardized doctors, actors playing the role of doctors. And you see here the doctors, there were men, women, Blacks, and whites, but they all read an identical script. And the script said, I, the doctor, have reviewed your tests, and I recommend that you have open heart surgery. The viewers of these videos were actual heart patients of different races and genders. After watching one of these videos, each patient only saw one video. They were asked some questions. One of the questions was, would you have the heart surgery based on what this doctor just said? Now remember, the doctors all read an identical script, and the results showed that the Black patients were more likely to agree to open heart surgery if recommended by a Black versus white physician. So if you're counting, that means that if we have more Black doctors, more Black patients would get their glucose checked, their cholesterol checked, a flu shot, and open heart surgery when recommended. And I bet then there are some of you who feel good about C as the answer. Let's continue. Clinical trials, as we know, are invaluable. They're an invaluable way for us to advance human medicine. But if they're going to be valuable to everybody, then they have to be based on studies in which we had adequate representation of diversity. When trials don't lack diversity, the outcomes are not generalizable, and we can miss important adverse and beneficial effects. The FDA is aware of this. And in 2016, the FDA declared 2016 the year for diversity. And they made a statement saying that they wanted to no longer approve drugs or devices if the studies showing that they worked were studies in which the clinical trial participants were not very diverse. That was in 2016 when the FDA made that statement. So let me show you some drugs and devices that have been approved since 2016. Maybe some of you have had the opportunity to use ivabradine, a new heart failure drug. In that study, upon which its FDA approval is based, only 1% of the patients are African Americans. Entresto, I'm sure you've heard of, fantastic drug. The study upon which its approval was based had only 5% African Americans. Blood thinner Cangrelor, which we use in a cath lab, the study upon which its approval was based had only 3% Black patients. And TAVR, a wonderful way to repair heart valves through a puncture in the groin. Patients go home sometimes the next day with a Band-Aid on their groin. The trials that showed this was effective had only 2% Black patients. So much for the year of diversity. Studies have shown that minority patients are more likely to consent to being in studies if the person asking them to be in the study has had cultural competency and diversity training or is a minority themselves. So there are probably some of you who feel good about D as the answer. More minority physician scientists will help diversify clinical trials, but we're not done yet. Let's talk a little bit about racial healthcare disparities. AICDs are absolutely life-saving devices that help to shock the heart back into a rhythm when it stops or goes into a deadly arrhythmia. And we know who should get defibrillators. The ACC and AHA give us guidelines. And I can tell you high on that priority list are patients who suffer from severe refractory heart failure and an ejection fraction less than 35% on goal-directed medical therapy. So I'm showing you two patients here. Look at your patients. Go ahead and look at them. And I asked the question, who gets the AICD? I hope you're thinking, well, of course, both. But that's not what the data shows. How about timely cardiac intervention? We know that in acute coronary syndromes, the early invasive strategy is superior. That is, doing the heart cath as early as possible to find the blocked artery and fix it helps us salvage more myocardium and save more lives. So look at your two patients on this slide who are both having an acute coronary syndrome. And my question is, who gets timely cardiac intervention? I hope in your mind you're thinking, why, of course, both of them, but that's not what the data shows us. And how about critical lower extremity ischemia? Who gets revascularization and who gets an amputation? We'll show you that the data shows that when it comes to ICDs, Blacks and Hispanics are not only less likely to get defibrillators than whites when controlled for the same diagnosis, but they're less likely to even be told about AICDs, to even be counseled about these life-saving devices when they are eligible to receive them. When it comes to revascularization, there have been decades of studies showing that Blacks are less likely to get timely and appropriate cardiac interventions. But a most recent study showed that Blacks, women, and uninsured are all independently predicted to have less timely coronary intervention when they present to the hospital with acute coronary syndromes. And the recent of many, many studies shown that Blacks and Hispanics who present with critical lower extremity ischemia are less likely than whites with the same diagnosis, the same level and severity of disease, less likely to get revascularization, more likely to get a limb amputation. We reviewed data such as these and found that in a 20-year period, over 300 studies like the ones I just shown you have been published, documenting Black-white disparities in cardiovascular care. In that 20-year time period, and after documenting it for 300 times, at the end of that time period, things were no better than at the beginning of that time period. These naggingly persistent racial healthcare disparities are parallel to a naggingly persistent lack of diversity in cardiology. While 17% of Americans identify as Hispanic, only 5% of cardiologists are. And while 13% of Americans identify as Black or African American, not even 3% of cardiologists are African American. Many who think about this, and count me in this number, are convinced that the lack of diversity is one culprit that continues to drive these racial healthcare disparities. So you're probably feeling pretty good about E, that we should diversify medicine because it'll help reduce racial healthcare disparities, but let's continue. This is a wonderful study published in Nature Communications by Al-Shibli et al. That looked at over 9 million research papers in the medicine and STEM literature, over 6 million scientists, and they were studying the relationship between impact of the research, which they defined as number of citations of the study, and several types of diversity: racial and ethnic diversity, discipline diversity, gender diversity, affiliation, what university you work for, and academic age, and by that they meant how long you've been in academia. Broadly, they found that diversity was positively correlated with impact. Discipline diversity and affiliation diversity were least correlated. The strongest correlation was with racial and ethnic diversity. So let me say that differently, because that really bears repeating. So you have a research team. This study that looked at 9 million papers and 6 million scientists found that diversity on that team strongly correlates with how many times the research that it produces will be cited. I hope that you're taking this into consideration when putting together your research teams. So maybe you feel pretty good about F as the answer. But as I said before, I'm well aware that you wouldn't be working at Stanford if you weren't really good at test taking. And so I suspect you probably have found me out, and that is that it's a trick question, because the real answer is all of the above. All of the above. So this is how you push back against that pushback when people say, why are you seeking diversity in medicine? So we know all this. We know that diversity will enhance patient-provider trust, result in more minority patients receiving evidence-based, guideline-driven care, reduce disparities in care, but we're still not there. But why aren't we there yet? What are the barriers, and how do we get over those barriers? Well, fortunately, diversifying our training programs is not just a good idea anymore. It's now a mandate. So now it is mandated by our accreditation body. The Accreditation Council on Graduate Medical Education, launched in July 2019. It is now live, that your training programs must show attempts to enhance diversity. So we wrote this as kind of a how-to, and it's meant for cardiology program directors, but it's applicable to say to program directors, don't be nervous. We'll show you how you can answer that ACGME mandate to enhance diversity. Step one, we all have to work on the deep pipeline and grow our own gardens. To the far left, you'll see one of our fourth grade programs that we did at Ohio State, where we invite fourth graders in to dissect hearts and learn about the heart. That young man I started mentoring as a fourth grader. This is him as a pre-med student. Let me go back. That's him as a pre-med student at Northwestern University, and that's him in my clinic in medical school. So from fourth grade to medical school. I like to say jokingly that I'm not sure how many more fourth grade to medical school cycles I have in me before I retire, but these are things that we can all do. When was the last time you sat down with a fourth grader, other than your own? I know you're doing it with your own, but when you sat down with a fourth grader and said, I think you can be a doctor. You can change somebody's life by doing that. So we all need to reach out to the deep pipeline. We need to mentor like there's no tomorrow. We put together an African-American male mentoring roundtable where we meet quarterly, the African-American male faculty and the African-American male students for socialization, for mentoring, for advising, because we are facing in a very short period of time now, we're going to have a crisis level shortage of Black men in medicine. So we want to make sure that those that are in medicine are on track for success. And we want to see if we can convince more of them to go into academic medicine. That was pre-pandemic, but on the pandemic, we just go to Zoom, no big deal. So I want you to imagine something for a minute. I want you to imagine that you are a first-year medical student, you're a Black male. Maybe you're suffering from confidence because you don't see many people like you. Maybe you're hearing microaggressions that are bothering you. Maybe you're the first in your family to go to college, certainly the first to go to medical school. And now you get on the Zoom call and you see smiling at you, looking at you, encouraging you. The first Black chair of anything at Johns Hopkins University, the chair of surgery, Dr. Bob Higgins, Dr. Andre Campbell at UCSF, a trauma surgeon who's on MSNBC every other week, the president of the National Medical Association, a vice dean of the medical school, all looking at you saying, you know what, you're smarter than me. So if I did it, you can do it too. Imagine how much that would lift you up. This is something that we can easily reproduce at every medical school around the country. And I'm happy to say that the Black Male Mentoring Roundtable has arrived at University of Texas Southwestern. We held our first session last month, and look at my friend, Dr. Wariaku here. You can see the jubilation on his face to be interacting with all of these Black male peers. We have to be visible, and that means everywhere that you can be, but also using social media. So as you know, we started this hashtag on Twitter, Black Men in Medicine, and we put out photos that will encourage people to go into medicine and hopefully change the nation's unconscious bias about Black men. So we want you to get on Twitter and follow this hashtag, Black Men in Medicine. Recruit actively. When I was Dean of Admissions, we noticed in 2013 at Ohio State that in our college's 100-year history, we had never matriculated a class of at least 50% women. We saw that as a problem. We put together a task force to study what's going wrong. What are we doing? Are we doing something that's turning women away here at Ohio State? And when we put into force some of the recommendations of that task force, we then have now had 8 years in a row at Ohio State, slightly more women than men in the incoming classes. And this is a very special picture to me because this was a time when I was making rounds on our acute coronary syndrome service. And this is my team. And all of these women I had admitted to medical school as the admissions dean. So this is active recruitment. This is looking at a strategy, changing it up so that we can change the face of medicine. Encourage our mentees to go into academic medicine. Dr. Sakima Smith and Dr. Simonette Jones were the first 2 Black cardiology fellows at The Ohio State University. We recruited Dr. Smith to stay on the faculty. We tried to get both of them, but Dr. Smith stayed on the faculty, and now this is him at the African American Male Roundtable, mentoring our students, and this is him in his NIH-funded basic science laboratory. So I mentored him, and now he mentors them, and we will try to get them to go into academic medicine too. We call that the mentoring cascade. Confronting implicit bias, we found when we studied our admissions committee that more than half had an unconscious association of a white face with good things and a Black face with bad things. We went right into an implicit bias mitigation workshop. And after that workshop, the next class we admitted was the most diverse class in our College of Medicine's history. So now we confront it, and it is part and parcel of being on the admissions committee, and we recommend it for GME selection committees as well. We have implicit bias mitigation workshops. It's actually not hard to override your implicit negative biases in the moment, but there are a few tools that you need to know to do that. Step 7, what if we actually made diversity or the ability to enhance the cultural competency of your program? What if we made that a priority? What if we made that a priority when we screened our applicants? What if we made it a priority when we're making our rank list? When I was Interventional Cardiology Fellowship Program Director at Ohio State, we did just that. We rated our applicants to our interventional program on collegiality, scholarly work, clinical excellence, and ability to enhance the cultural competency of our program. So that means that our interventional cardiology candidates were rated on whether or not their letters of recommendation specifically cited cultural competence as a trait. They were rated on whether or not they've participated in community outreach activities, whether or not they have been exposed in a meaningful way to cultures other than their own, and whether or not they have been exposed to patients from an underserved and disadvantaged background. What if we all did this? What if we all made this one of our priorities when we screen for our medical school, residency, fellowship, or even on our faculty search committees? What could it look like? It would look like this. These are interventional cardiology fellows in 8 consecutive years at The Ohio State University. And this is what it looks like when you truly value diversity and when you truly believe that diversity enhances quality. So every year for the last 8 years, at least one of our interventional cardiology fellows has been an underrepresented minority, and they have helped us to enhance our patient care. So in summary, there's a global call to end systemic racism in all aspects of life. We have a role to play. Academic medicine has a role to play in ending racism. In response to some of the horrific events, including the racial disparities seen in COVID care and outcomes, academic medical centers have stepped up and made bold anti-racism statements. But what I want to leave you with is that the most powerful anti-racism statement that we can make is to diversify our ranks. Thank you very much.
Dr. Capers, thank you so much for that wonderful presentation. I remember roughly a couple of years ago, when you came here in person, I was sitting on the ground on the stairs because the room was so jam-packed coming to see you, and no surprise, once again, amazing speech. Thank you so much for speaking with us. I want to just get right into questions with our remaining time. The first question that pops up here, Dr. Clark is asking, why not more Black women being encouraged and mentored from the 4th grade on? I remember you spoke a lot about this last time, women cardiology, and promoting that as well, but any comments on that here?
Oh, we are for promoting all diverse groups. I might have seemed like I concentrated on Black men because of the 2015 study that came out of AAMC, showing that there were fewer Black men applying to medical school in 2014 than in 1978. And what that means is that in a very short period of time, Black men are going to be a real endangered species. But if I were to put my slides back up again and show you those 4th graders at Hart School, about half of them were girls. So we also are very happy to work on defining diversity broadly, and it's not just about Black men. It's people of color, it's women, and it's our brothers and sisters in the LGBTQ community as well.
Yeah, I remember you spoke a lot about that, particularly bringing women to the cath lab, and that was a big part of your presentation. Something you, and on Twitter as well, you're always talking about that. So thanks so much for all that. And by the way, for those of you who haven't followed Dr. Capers on Twitter, he has an amazing Twitter handle, and please do follow him. Next question, Dr. McGreevy asks, Dr. Capers, are current CDC race and ethnicity delineations sufficient in identifying diverse ethnic groups for the purpose of clinical intervention and care?
Excellent question. And so I'd have to familiarize myself with differences if the CDC has changed the way they're defining diversity. I think what the question is getting at is, are the categories of race and ethnicities used by CDC adequate to deliver the best clinical care? They certainly have traditionally been the same ones that we've used. Whether or not they could be updated, I suspect they could be updated. But I'm going to say on that, let me go and look specifically at what they're using before I answer that question for you. If that's not the right answer, then please re-enter it, and I'll try to get more to what you're asking.
Thanks so much. A quick follow-up for that first question. Dr. Clark just says, thank you for showing the increasing number of Black women at Ohio State University and for mentoring at an early stage. I'd like to pop over to Dr. Harrington, who has like to ask a question.
Great, Quinn. First off, again, thanks for being with us, and thanks for sharing all the information that you are. A lot of what you're talking about strikes me as it's the pipeline. It's recruiting early, getting them into the fellowship program, and then figuring out, how to move them along into the faculty by appropriate research, training, et cetera.
Mhm.
One of the challenges that we're facing here is, as part of a larger university, there are very I will call old-fashioned views of how one ranks academic success when we're recruiting faculty, particularly mid-career to senior faculty. Things like what do people in that field say about you in the so-called letter of reference. Can you give me and my leadership group some tips on how we might deal with that?
Thank you, Bob. I think I'm such a fan of having an overarching or guiding mission to kind of guide what we do. And I would say it's a good exercise to look at the mission statement of the medical center, of the School of Medicine, of the Department of Medicine, and what is it that you're trying to achieve? I would bet there are probably a lot of words in it, but I bet it comes down to we want to impact humanity in some way. And so I think an exercise, maybe a retreat, to look at that and say, what are ways that we can help impact humanity? Yes, if we promote people on the faculty who have sequenced and cloned new genes, that's helping to impact humanity. But if we are doing research or community engagement that is convincing more people of color to take the COVID-19 vaccine, is that not also impacting humanity? And maybe it's not peer reviewed, or maybe it's not in the highest impact journal. But is our goal to put research in the high impact journals, or is it to have a beneficial impact on humanity? So this is maybe something for a retreat to really talk about. You're familiar with, because we've had conversations with it before, about the disparities with NIH funding, and that the NIH just doesn't find sexy racial healthcare disparities, diversity, and equity type research. So those proposals are less often funded, which then leads to this cycle of if I'm a department chair and I'm supposed to hire people who have NIH funding, there's already an imbalance there. So I think we need to look at our mission and say, is our mission to have certain publications, or is it to help mankind?
I may have you come to our retreat.
Great. Dr. Capers, I got a question for Dr. Valentine, and then I'll also have a question from our Associate Chair, Diversity, Dr. Dunn, after that. Dr. Valentine asks, thank you for an outstanding and practical guidance for all committed to diversity. Can you comment on the role of institutional accountability to ensure the adoption of those excellent recommendations?
Yeah, wonderful question. And hello, Dr. Valentine. I'm honored that you joined us this morning. So accountability is so very important. In fact, I was just having a conversation with some leaders here at UT Southwestern, and I made this analogy. I said, if you hire me as a department chair, and you say, okay, Quinn, now to get reappointed, your reappointment metrics are going to be, did you get your clinical RVUs up in your department? Did you get the NIH research up in your department? And philanthropy to your department. Those are the three metrics. So when we sit down with you in 3 years to see if you're going to continue, you've got to show progress in those areas. And then as I'm walking out, you say to me, oh, by the way, Quinn, diversity is pretty important too. Well, you're sending me a message. And so I'm going to put my attention on what's going to get me reappointed. And diversity is going to wind up being number 27, 28, or 29 on my priority list. So we need our senior leaders to put some teeth into this and not just say, yeah, diversity is pretty important too, but how about making our leaders accountable? And we can work with you. We can make it easy to be accountable. We can make it so that when a chair or a division chief or a center director sits down for their annual evaluation, we can make it easy for them to show that they've done something to move the needle and change the culture. Maybe it's they've had 2 grand rounds dedicated to diversity. Maybe it's that they've hired 2 more women or 2 more Hispanics or African Americans. Maybe that they've instilled some racial healthcare disparities curriculum in their department. We can make it easy that if we make it an expectation for which you will be held accountable, that all of our leaders are doing, that's how you change the culture of an institution. And so I'm sorry I got long-winded there. The short answer is we need senior leaders to say, this is more than just a good idea. It's more than just a notion. This is something that we're going to do, and we're going to make everybody accountable for it. Accountable maybe to get your bonus, accountable maybe to get your reappointment.
Great. Dr. Capers, we have Dr. Dunn, one of our newly appointed associate chairs of diversity.
Hi, Dr. Capers. Thank you so much for that incredible talk. I mean, clearly you make a very fantastic data-driven point on increasing and improving diversity at institutions. What I wonder is, and I also want to say I was really struck by your daughter's painting. That was really impactful. So thank you for sharing that with us.
Thank you.
I wanted to ask you, what are one or two concrete ways that you've seen in your institutions where you can ensure that after bringing diverse trainees and faculty to your institution, that you create an environment that is inclusive and one of belonging, so that those people feel safe and included and want to stay in that environment?
So I like the idea of education. So, you know, we're clinicians and scientists and researchers, but we're also educators. And I like the idea of educating everybody about what the value of diversity is, and how we can get away from the microaggressions, the macroaggressions. Often people might say things, they might think they're being funny or humorous. They might not know that it's offensive. Now, sometimes they know they're being offensive. But what if we had a teaching session on a regular basis? In fact, I wrote a paper on this in Chest called Bias and Racism Teaching Rounds. What if we quarterly had something like a morbidity and mortality conference where we just discussed, where we had collected racist incidents, and we discussed, not in a way to blame anybody, not in a way to be punitive, but in a way to educate people. So this is what was said. Let's dissect that. Just like you would dissect at an M&M, somebody got the wrong dose of heparin. And we all learn from it so that next quarter we have fewer of these incidents. So taking, I think, an education approach rather than a punitive approach, I think we'll get more buy-in.
Dr. Capers, we also have a question from our panelists, Dr. Upi Singh.
Hi, Quinn. I'm a former Buckeye as well. So
I remember you, Upi. How are you?
I'm well, thank you. Nice to see you. Thank you for a great talk. I wanted to ask a question. I want to make it a little challenging for all of us. You know, I think it's great to see what you're doing in cardiology and in other specialties, but I would encourage us to think about certain specialties in infectious diseases, obviously close to my heart. We actually have pretty reasonable diversity. It maybe isn't as good as it should be. Maybe, of course, it can always be better. But why is it that some specialties maybe either inherently have more diverse applicants? Is it because we focus on global health, underserved populations? And what can we learn from those specialties? I think that would be something really important to think about. Thank you.
Well, thank you. And you know, Upi, I was having a conversation with our chief of infectious diseases here at UT Southwestern, and we talked about this. And Dr. Pearl's idea was that as a specialty, it's almost ingrained in the specialty. When you look at, these are the doctors who are treating Ebola, who are treating AIDS when AIDS first really exploded. And so there's something about people drawn to that specialty who have this global outlook that you know, all humanity is worthy. But I think you're right. I think ID can certainly teach cardiology a few things. I'll tell you that.
Thank you.
Dr. Capers, I want to be respectful for your time, but we have so many questions coming in. Do you mind if we go about 5 minutes over, or are you okay with that? Or
5 minutes over is okay with me.
So thanks so much. I'm going to hop over back to our Q&A, and then I'll come back to our panelists. Dr. Marion Buckwalter asked and said, great talk. I'd love to hear more about using rubrics to assess diversity and comfort with diversity. And do you think something like that would help as criteria for faculty selection? Is any school doing that?
So thank you for that question. I agree with you. I like tools. I like tools that give me something I can put in my hand that can help me at least optimize the chances that will enhance diversity. So I like point score systems. I like using such tools similar to the one I showed you at the screening stage, at the interview stage, and then again when we're deciding who we're going to rank. And I like doing the same thing with faculty search committees and especially leadership search committees. It's interesting when you think of the house of academic medicine, the students are entering, and then GME, and then faculty selection. If you look at most medical centers, or many, those who have a diverse student body, you have a lot more diversity in your student body than you do in your GME, and then much more in GME than in your faculty. And I think that says something slightly about the people who are doing the selection. I think admissions committee members, and this is a former dean of admissions, they tend to very easily grasp the concept of holistic review. And let's look at how we can diversify, because diversity enhances quality. At the GME level, they tend to be a little less likely to embrace that and more likely to say, I need step one to help me screen all these applicants. And then at the faculty level searches, it tends to be more how many publications do you have in Cell and Nature. So I think these rubrics can be very helpful. It takes out the subjectivity, takes out bias. Part of the question was, am I aware of it being done at a faculty search level? I'm not aware of anything being published, but that doesn't mean it's not being done. But I'm in favor of it. And it's something that I'll, as I finish up my listening tour, I'm still in my listening tour. I've been here for 2 months. It's something that I'll be working with others to propose.
Thank you, Dr. Capers. Dr. McGee has a question for you.
Yes, good morning, Dr. Capers, and thank you for your comments on infectious disease. I'm an infectious disease specialist, and we like to think we do things with culture and sensitivity. My question has to do with the historically Black medical schools, which continue to turn out the majority of African-American physicians and have been somewhat stagnant in terms of their growth. And the newer medical schools that have been established have really not fulfilled their mission of recruiting more minorities. So the question is, what can we do to support historically Black medical schools? And what pressures can we put on new schools to really fulfill their missions, which is why they were given permission to launch? So I'll stop with that.
Yeah. So what a great question. And so you're right. Our HBCU medical schools, the historically Black college and university medical schools, continue to play really an outsized role, just as you said, in producing Black physicians, and they really show us how to do it. So they really can teach us a lot, right? So if we are still struggling, at a Duke medical school or a Yale medical school with saying, oh, I'm not so sure if I should take this student with a slightly lower MCAT, I'm not sure they'll do well. Well, our HBCUs take them and turn them into outstanding doctors. So they have a lot that they can teach us. So they need financial support, because all of them are although some of them just got some pretty big gifts, they could use even more gifts. And so in addition to financial support, I think what we can do at majority institutions is partner with them for pipeline programs, for taking their students, for visiting clerkships, and looking to actively recruit from their students for our residency and fellowship programs. Now, I'm sure that Howard, Meharry, Morehouse, and Drew would say, we don't want you to poach all of our talent, but we could partner with them to get more opportunities for those students. And actually, one of my stalwart in academic medicine that you all know, a giant, Clyde Yancey, in a recent perspective piece actually said, we're starting all these other medical schools, maybe we need another HBCU medical school, because they have really, for more than a century, some of them, shown us how to do this.
Dr. Capers, we're just past 9:05 here, and I want to respect for your time. I just want to say thank you for all the people who have asked questions we don't get to. Some great questions about male doctors, white male doctors, and lots of great comments. Thank you so much for a wonderful presentation. I also want to acknowledge there were some questions about the Asian minorities as well. I apologize we didn't get to those. For those of you who do like us to talk about this or present this in the future, please email me. We want to make sure we're covering all topics that are important to our community. Again, Dr. Capers, it was as amazing as we expected. Thank you so much for joining us virtually. We hope to be able to invite you back in person in the near future as well. Thank you for a very engaging, wonderful presentation and answering all these questions. And it was an honor to have you with us today.
Thank you all so much. Have a wonderful day.
Thanks, everybody. And thanks to the panelists. Have a good week.